We will be making our transition to the presentations in just a few minutes. Okay, if you could please make your way to your seats, we're going to start our presentations briefly. Thank you. Family members, friends, fellow faculty, and most of all this evening, our students. Thank you for joining us this year for our research forum. We're proud of the research our Doctor of Physical Therapy students have carried out. Before we begin our presentations, let's have a round of applause for all the excellent posters that our students have produced. We would now like to proceed with 4 presentations that highlight a combination of student projects as well as research performed by our faculty. We will have a 15-minute question and answer session at the end of the presentations, so we ask you to please hold your questions until that time. Thank you. To begin, I would like to invite Danielle Berkey, Anna Stillberger, Keely Smith, Allie Jacobs, and Amber Titchener to the stage to present their research project entitled Correlation Between Hip Rotation Strength and Low Back Pain in Females. This project was directed by Dr. Nicole Schrader.
So before we get started, we'll do a quick introduction. I'm Danielle Berkey.
I'm Amber Titchener.
I'm Anna Stillberger.
I'm Allie Jacobs.
And I'm Keely Smith.
So for our study, we did the correlation between low back pain and hip rotation strength in females. So kind of a background and purpose on why we did this. There's many studies that have been conducted on hip range of motion and low back pain in males. However, there's less known about females, and there's less known about hip strength and low back pain. So the study looked at the incidence of limited hip internal and external rotation strength in females and its correlation with low back pain. And our null hypothesis was there will be no correlation between low back pain and hip rotation strength in females. So our participants, we had 51 healthy females between the ages of 18 and 65, and these were with or without low back pain. And all participants were recruited here at the University of Findlay. Our exclusion criteria were males, females less than 18 or greater than 65, anyone who was pregnant, and anyone who had an orthopedic surgery or a hip injury in the last 6 months, and then anyone who couldn't provide written consent.
So each participant, when they arrived, we collected an informed consent and gathered general data about them, including age, gender, presence of low back pain, and we grouped them into 0 or 1 if they had low back pain or not. We had participant height, weight, and BMI obtained via a standard scale. Participants underwent testing of bilateral hip internal and external rotation strength to the protocol described in Muscle Testing and Function by Kendall. This is pictured on the left here. The MMT process was described to the participant to ensure their understanding. Participants were categorized into 2 groups, those with a reported history of low back pain in the past 6 months, categorized as a 1, and those without a reported history of low back pain in the past 6 months, categorized as a 0. These are just the procedures for manual muscle testing for hip internal and external muscle strength. The left hand, on the left-hand picture, testing internal rotation was used to block, and then a force was applied to the outside of the ankle with the right hand. And then the hands were just reversed to test external rotation muscle strength on the right-hand picture.
So here we get into our statistical analysis. So as you can see on the right side, we have a chart that shows the MMT score, which is just the physical therapy kind of way of describing how we test muscle strength. It stands for manual muscle testing. And this is just kind of a standard of practice across our profession that allows us to demonstrate strength. So for example, a 5 out of 5 is they were able to perform full range of motion against full resistance. And then for example, a 4 out of 5 might be they were able to do a full range of motion but only hold up against moderate resistance, just to kind of give you an example. And then to the other side of the chart is just a decimal correlation. So our software that converted all of our statistical analysis was then able to kind of take that manual muscle testing score and give us a decimal conversion so that we were then able to get some good results down and give us kind of an average MMT strength of the hip internal and external rotation for each group. So then moving forward, we were able to, from this data, pull a t-test up, and that's just kind of showing the difference, if there was a statistically significant difference between the groups, and our groups being hip internal and external rotation strength between females with and then our females without low back pain. And then a Pearson correlation was performed to determine if then there was a relationship between each hip strength variable and low back pain. So then kind of moving on here, for example, you see in this chart, it's just broken down between our 2 groups, the with low back pain and without low back pain, and then kind of broken down between whether they were hip internal and external rotation, as Amber kind of described before. And then that decimal conversion was what our chart came out with. So for example, for 4.24, if you go back to this chart, you can see on the right side of the chart, it has 4.25. So the 4.24 here would be equivalent to a 4 plus on the manual muscle testing scale. And then getting into results. So when we ran this p-value, and our p-value is kind of just to see if there was a statistically significant difference noted between the groups. And all of our numbers, as you can see, our p-value was set to a 0.05, and all of these numbers here are greater than that. And I will kind of let them talk about descriptions, so just keep that in mind as we kind of move forward.
All right, getting into more results, we have the R value that we looked at in our analysis, and that basically correlates between hip internal rotation and external rotation strength and low back pain, and how strong they are when we looked at them. We also did a t-test, which compares our groups of low back pain and non-low back pain patients, and how their external and hip external and internal rotation strength is. We didn't really find a significance between those 2 groups. And then this is just our Pearson correlation. Overall, we didn't find significant correlations between low back pain and age, low back pain and the BMI, which is your body mass index. There was no correlation between right hip external rotation and low back pain. There was a small correlation between left hip external rotation and low back pain, and there was a small correlation between right hip internal rotation weakness and left hip internal rotation weakness and with low back pain. And then those R values that I took earlier basically shows you the correlation and how strong they are, small, medium, and large.
So to begin to sum everything up with our conclusion, as Anna said, we did find a lack of correlation between age and low back pain, but this is in agreement with many other previously published research that has also found that low back pain can affect women of middle age, doesn't matter if they're at the beginning of middle age or more towards the end, and that their level of low back pain or their status usually doesn't change as they age. And then previous research has found a correlation between obesity and low back pain, obesity being more than 30 on the BMI scale. In our study, we did not find a correlation between their BMI and low back pain, but this could be because our average BMI was 28, so that's below that threshold of 30 that's considered obesity. So that could have played a role in our results. And then, as Anna said, we did have a small correlation between bilateral hip internal rotation as well as left hip external rotation strength and low back pain. And again, this is in agreement with many previous research that has found that hip extension and abduction can correlate with low back pain. So this is just something to keep in mind as we go into the clinic to really make sure we are testing these different areas to see if this could be causing some of our patients' problems with their pain. And then as for our study limitations, we did have a small sample size of 51, but as I stated in our previous slide, a lot of our results were in correlation with previous research, so that just goes to show that our sample size may not have played as big of a role on our results as what it could have. And then we also did have a broad age range of 15 to 65, which makes these results hard to apply to a single patient. But since we did have a broad age range, that means these results are applicable to a broad range of patients in the clinic. And we did have a lack of diversity secondary to our participants being recruited from this small rural college. But once again, a lot of our results were in agreement with previous research, so this may not have played as big of a role on our results as what it could have. And then manual muscle testing, since it is done by a clinician, it is a subjective measurement, but we tried to accommodate for this by having the same person perform the manual muscle testing each time. And it's been proven that intra-rater reliability, or having that same person perform the manual muscle test on each of our participants, is a much higher reliability than inter-rater reliability, or having a different person complete the manual muscle test for each patient. And then previous research has also showed that having a clinician manually do this type of strength testing is actually more reliable than having a machine do it. So once again, enhancing the reliability of our study. And kind of in conclusion, correlation does not always mean causation. So in other words, everyone with hip internal weakness or left hip external rotation weakness may not always have low back pain and vice versa. But as I said before, this is something that of course we need to keep in mind in our clinic since we have found a correlation between it. But then of course we need to make sure we are still doing a comprehensive evaluation and looking at all the different factors that could be playing a role in our patients' low back pain to come up with the best treatment for them. And do we have any questions?
Thank you for your presentation. We'll now have Christine Schubert Courtney Arf, Leanna Burke, Meredith Gardner, and Mitchell Matchok present four-square step test with and without dual task among older adults with and without fall history. Dr. Mario Baker directed this research project.
Hi, everybody. We're going to start with a little bit of an introduction. My name is Meredith Gardner.
My name is Christine Schubert.
I'm Leanna Burke.
I'm Courtney Arft.
My name is Mitchell Matchok.
All right, so our research was the four-square step test with and without dual tasks among older adults with and without a fall history. So overall, our original study question was, is the four-square step test with dual task more indicative of identifying community-dwelling older adults with a fall history than the four-square step test under normal conditions? Therefore, our hypotheses were those with a fall history will demonstrate an increased time on the four-square step test with and without dual tasking compared to those without a fall history. Individuals performing the four-square step test with a cognitive dual task will demonstrate an increased time to complete the test when compared to the four-square step test without dual tasking. And lastly, the four-square step test with cognitive and motor dual tasking will identify those individuals with a fall history better than the four-square step test alone without dual tasking. And also keeping in mind the definition of a community-dwelling older adult being an adult 60 years of age and older and still independently living in the community and independently functioning. So overall background and significance. The number of individuals living beyond 65 years is increasing and will continue to increase in the coming years. However, with this, the prevalence of falls is also increasing. In addition, falls among older adults cause 34,000 deaths and 3 million emergency department visits in 2019 alone. In addition, the World Health Organization classifies falls as the second leading cause of unintentional injury deaths worldwide. Also with this, older adults are more likely to experience repeated falls if they have a history of falling. So oftentimes individuals that experience a fall might just brush it off or not think much of it and not seek any intervention such as physical therapy. Fall prevention is only effective if appropriate balance assessments are identified. And in this case, the four-square step test is a validated tool utilized in physical therapy practice to identify older adults who are at risk for falls.
So our study had a total number of subjects of 50 participants, 35 of which were female and 15 were male. The background was primarily of white, non-Hispanic descent. And the average age of participants of the study was 74.1 years of age, with a standard deviation of about 74.1, with a minimum age of the participants of 60 years old and a maximum age of 101 years. As far as reported falls, an average of 0.76 falls were reported per participant, with a minimum number of 0 falls and a max number of 8. And of the participants, 56% of those denied having a fall history within the past 12 months, while 44% reported having a fall history of at least 1 or more falls within a 12-month period.
All right, so diving a little bit into our methods, just based on time constraints, this was conducted as a retrospective cohort study, and then we used a sample of convenience from the communities surrounding the University of Findlay. Primarily research conducted out of University of Findlay here, where participants came to us, although we also went to 50 North, which for those not in the Findlay area is a Senior Fitness Center. We traveled there to recruit participants, as well as Taylor Place, which is an independent living facility. Participants were given informed consent after explanation of all of the purpose and testing procedures. So a little bit more about our inclusion and exclusion criteria for this study. Individuals had to be a community dwelling individual greater than or equal to 60 years old, as based on the World Health Organization definition of an older adult. Had to be able to communicate and follow at least 3-step commands. They had to be able to independently ambulate at least 20 feet with or without an assistive device. They had to be independently performing their activities of daily living. And we also administered mini mental state exam, which they needed to achieve a 24 or higher out of 30 on. Individuals that were excluded from our study generally were individuals that had a medical condition that prevented full participation in their balance or cognitive testing. So some of the specific conditions that we excluded included vestibular disorders, people who had blurred vision or double vision, if they had any musculoskeletal injury of any kind that would influence their walking ability, as well as any neurological disease that would impair their walking ability, such as a stroke with residual deficits, Parkinson's, and then dementia diagnosis would be the last one, as well as just anyone who has pending litigation was excluded. So materials here, so this first participant screening interview questionnaire was basically just a survey kind of that we gave individuals. It included demographic information that we listed on an earlier slide, as well as made sure they fit all of the inclusion and exclusion criteria so that they would qualify for participation. We also administered the mini mental state exam, which is just a measure of cognitive function. We did do the 4-square step test, which is primarily what our research is based off of, which is this test right here. This is the diagram. It's kind of confusing, but basically, individuals start in square 1. They face forward the entire time. The PVC pipes are these lines here that would make up the 4 squares. Individuals start in square 1, facing forward, take a step with each foot into step 2. They step sideways steps into 3, backwards into 4, sideways into 1. Still facing forward, they have to go then back around over the pipes, forward, back, and then all the way back to 1. We used a cup of water for our motor task, which we'll touch on later. And then we also administered timed up and go, which we did with dual task, a cognitive dual task. And then as all good PTs do, we did use gait belts.
For the procedure, we started by taking vital signs of each participant to rule out any safety concerns. The vital signs that we assessed included blood pressure, temperature, heart rate, as well as respiration rate. The participants then performed 3 variations of the 4-square step test, including the 4-square step test alone, the 4-square step test with a motor task, which, as Leanna alluded to, was holding the cup of water while performing the different sequences of the 4-square step test, as well as doing the 4-square step test with a cognitive dual task, which we had of reciting every other letter of the alphabet. We would start the participants off with the ACE to give them the idea of the flow that we would like them to do for the cognitive part. It's important to note, though, that we did count the errors that were recorded for each section of the 4-square step test in order to minimize the practice effect of doing it multiple repetitions. Errors included examples such as stepping on the PVC pipe or initially improperly doing the step sequence. Following the 4-square step test and the different variations, the participants performed the timed up and go. For those of you who are unfamiliar, the timed up and go is when a participant is seated in the chair, they stand up, walk a 10-foot distance around a cone, come back, have a seat, and that is the test. We did that with the participants using the cognitive dual task of reciting the alphabet every other letter, just as we had done with the 4-square step test variation. We had utilized the tug as a set procedure, and it was not analyzed as a section of our study, however.
So I was going to speak to some of our pictures here. So Mitchell performed the timed up and go with our participants while I performed the 4 square step test. So as we stated before, some of our participants are pictured here with their consent. They were 35 females and 15 males. They were all community dwelling and under the age of 60, or forgive me, the age of 60 or over. Not many of them had assistive devices. I did want to move to another picture where someone did bring an assistive device. We had several people that did bring in canes. Some of them set their canes aside while they performed this test, but others of them also used their assistive devices. This was not a part of our exclusion criteria, so they were able to use their assistive device while performing the 4 square step test. We didn't control for any clothing or shoe wear. Most people would wear sneakers or whatever they were comfortable in. Like Courtney said before, we did record our errors. We didn't specify what type of errors that happened, just if one occurred, and we did not stop for errors. And I wanted to add a few more errors that we did count. She stated stepping on the test or hitting the 4 square step test PVC pipes, a loss of balance, if they had an error with the alphabet or spilling the water, or a directional change that wasn't instructed, or possibly stepping on my foot while we were doing it.
To analyze the data, we used the Jamovi software for statistical analysis. We had first did a descriptive statistics analysis conducted to characterize the sample. The area under the curve of the receiving operating characteristic curve was calculated and used for the 4 square step test with and without the dual tasking to determine which test variation best discriminated between falling and non-falling participants. The cutoff scores for the tests were then determined using the data from the ROC curve analysis, which selected the highest sensitivity and specificity.
So as she just talked about, this is that receiver operating curve here. I'm just going to walk you through all these different colorful lines here, and just try to keep you guys from losing track. So the first dark blue line that you can kind of see right here, that is the 4 square step test alone for males. The red line here is a 4 square step test alone for females. This green line here is the 4 square step test for males with motor dual tasking. And the yellow line here is the 4 square step test with motor dual tasking for females. And then the gray here, which is kind of tough to see, but it runs right through there, that is your 4 square step test with a cognitive dual tasking for males. And then the light blue, which kind of runs up through here, that is your 4 square step test with cognitive dual tasking for females. So respectively, for females, we'll start there and talk through the results of that based on the area under the curve that we received. For the female 4 square step test, the area under the curve was 0.63, which would be your red line there. The motor dual task area under the curve was 0.69 for females, and then the cognitive dual task for females was 0.66. And then as far as the males go, the dark blue, which is right there, the 4 square step test area under the curve was 0.51. Additionally, the motor dual tasking for males area under the curve was also 0.51. And then the cognitive dual tasking area under the curve was 0.73 for males. So what does this all mean? So it's just important to preface this by saying that we compared our participants of the study to other members of the cohort in the study, and we compared that to generate our data. So first off, the 4 square step test with cognitive dual tasking was better than the 4 square step test alone when discriminating between both male and female fallers and non-fallers. In addition, the 4 square step test with motor dual tasking was more accurate when looking at female fallers versus non-fallers. However, the tests under the same criteria for males, they proved to be equal. And as far as the cutoff scores go to determine the time that they would be at a fall risk, for the 4 square step test, that time, the cutoff score was 10 seconds with a sensitivity of 72% and a specificity of 57%. The 4 square step test with motor dual tasking, that cutoff time was also 10 seconds with a sensitivity of 81% and a specificity of 53%. and the cognitive dual tasking, that cutoff time increased to 13 seconds with a sensitivity of 72% and a specificity of 42%.
So we did have several limitations to our study. First off, physical therapy following any of the falls that our participants had was not considered in our criteria. So receiving treatment for a fall could have influenced the results after our time with our patients. This was a retrospective cohort study, so we did not look at the incidence of future falls after our time with our participants, only past falls. The study does have very limited generalizability. Our demographic consisted of white non-Hispanic males and females that live local to the University of Findlay or local to Findlay, Ohio. And most subjects were healthy individuals within the population that we had. Many regularly exercised and were members of 50 North, which is that fitness center down the street. These are also self-reported falls, so there was varying understanding as to possibly what a fall meant to our participants. So it's possible that somebody who reported no falls in the last 12 months actually did have a fall. And there was a little bit of a practice effect with the 4-square step test as well. Patients had to complete 4 full 4-square step tests. I gave them an example. They would have a practice run. They would go through 1 4-square step test, 1 with the motor dual task, and 1 with the cognitive dual task. So we did see that their times completing the 4-square step test did get a little bit faster with the motor and cognitive dual tasks, even though they were supposed to be a little bit more difficult. We liken that to being able to do the 4-square step test multiple times. So we did conclude that for comparing within our cohort of subjects, that our study's findings did suggest that the 4-square step test with motor dual task in females and cognitive dual task in both males and females could be used by clinicians as an alternative assessment to discriminate between community dwelling, older adult fallers and non-fallers. These are our references. You can also feel free to scan our QR code. If there are any questions, please let us know. Otherwise, thank you very much.
Dr. Schnifke, what's your question?
So ideally, moving forward, we'd probably like to perform a prospective study rather than a retrospective study. And we would focus on, seeing if they would have any future falls based on the scores that they were at this given point. So whether that's following up in anywhere from 6 months to a year. As well as, I think we would ideally like to have a more a diverse demographic, and also possibly a larger population of participants. Yes?
What did you guys explore the definition of what a fall was?
So we did tell participants, we defined a fall as anytime you unintentionally end up on the floor when you don't expect to be. We did also tell them, furniture counts too, if you're falling into furniture. There were individuals that still told us no falls, even though they really, they give you that but they still reported no falls. So that's definitely another thing that you could look at with a prospective study, asking them, okay, you just had this fall, what was that fall like? And then us being able to interpret the information ourselves versus having them just report to us.
Thank you to our student groups who presented tonight. We'll now highlight research being performed by our faculty. Dr. Jason Ashby will now present the prevalence of learning disabilities in licensed physical therapists and physical therapist assistants.
Hello, everyone. I'm Jason Ashby, one of the faculty here at University of Findlay. And we're going to talk about, as Dr. McBride said, prevalence of learning disabilities in licensed PTs and PTAs. But first, I'd like to talk about specific learning disabilities because there's a lot of myths and misconceptions about them. To have a diagnosis of a learning disability, really, which is a poor term, it's more a learning difference. Someone has to have average or above intelligence. These people aren't stupid or unintelligent, they just have difficulty learning in certain ways. We know that socioeconomic factors play a role in one's ability to learn. This is not that. Also, this does not have anything to do with poor vision or poor hearing, or what we call modality deficit. Also has nothing to do with poor instruction. Right? It doesn't have anything to do with the teacher. There are several different types of what are termed specific learning disabilities or learning differences. We're not going to go through all of them. We're going to go through a couple of them that are more specific to this study and more specific to physical therapy education. Okay? So the first one is auditory processing disorder. This is not difficulty hearing. This is difficulty interpreting auditory information. Right, so this has been found to originate in the central nervous system, and it can occur congenitally. It can also occur with age, after a stroke. There is a theory that it tends to occur in men after about middle age. So if you have a, if you have a significant other who might not appear to be listening, if there's something else going on, the TV is on, if they're doing something, their attention is diverted, it's not that they're not listening, it's that they are actually unable to process the information. So, guys, you're welcome. Dyslexia. This is the most common specific learning disability. This is where a lot of myths about learning disabilities reside. This has been found to originate in certain areas of the brain, which actually depend on the type of language learned. Someone can actually have dyslexia in a certain language or a certain type of alphabet, such as logographic, so where we use an alphabet A, B, C, right? Like our students were trying to alphabetize themselves earlier. We can work on that later. But they can have dyslexia in that type of language, but in a pictographic alphabet or language such as Chinese, Japanese, they can have no difficulty reading those symbols. There's actually been case studies describing that. This has nothing to do with seeing letters backwards, which is commonly thought. That happens in most children when they're learning to read. This dyslexia is difficulty associating phonemes with letters or knowing what sounds which letters make. There's different types of learning disability, or excuse me, of dyslexia, but they all have to do with that. And what's interesting is individuals with dyslexia, if they only have pure dyslexia, they have no difficulty with math. They can identify numbers and what they mean. The problem is only with letters. Nonverbal learning disability. This is individuals, they may seem very, very bright. They have high learning aptitude in most ways, except they have difficulty with nonverbal communication. This has been likened to autism spectrum disorder, some of it formerly known as Asperger's. However, this has been found to originate in a different area of the brain. Then some related conditions, which aren't thought to be learning disabilities or learning differences, but can absolutely affect learning. Some of them, the most common one, ADHD, is thought to affect up to 15% of the population. It's multiple theories about it, a lot of misinformation about it. It's thought to be related to dopamine or norepinephrine deficiency. There is a very high comorbidity with learning disabilities and ADHD. 25 to 40% of individuals with a learning disability have been diagnosed with ADHD, and 30 to 65% of individuals diagnosed with ADHD have been diagnosed with a learning disability. There's a lot of misconceptions about this as well. Some people say, oh, this is new. I never heard about this when I was young. This has been around for 250 years under different names. It was first described in 1798, hyperkinetic disorder, defect in moral control, which I thought was kind of an interesting label, post-encephalitic behavior disorder, minimal brain dysfunction, attention deficit disorder, ADD, which is still used in educational parlance, and now attention deficit hyperactivity disorder, which again is a very poor name because hyperactivity is one component or one type. There's also an inattentive and a combined type. So a very poor generalized name. Some other disorders are listed here. I'm not going to really get into most of them. One of them of importance is a modality impairment, or an impairment in vision or hearing, or an impairment of sensation of some kind. So now we'll get into results of the survey. This survey was sent to 24,000 plus licensed physical therapists and assistants. We had 409 individuals complete it for a whopping 1.7 response rate. So what is your profession or what is your license would have been a better question. We had much more PTAs complete than PTs. We had a lot more females complete the study than males. One individual identified it as other. A couple decided not to say. As time goes on, there's a lot more online education, a lot more hybrid programs, so I was interested in seeing if that had any relation. And by and large, most of the respondents were from traditional on-campus programs, which might be a limitation considering the amount of graduates who are graduating from hybrid programs. Okay. Then when did you graduate? So we have a lot of new grads relatively completing the study compared to older therapists. And then we have diagnosed. Did you have a diagnosed learning disability or related disability? We had 10.76% of the respondents say yes. Now the CDC estimates that 13% of Americans have a disability of any kind, and 5% of the general population. Now researchers involved in learning disabilities strongly disagree with this. They say the number should be closer to 20%. However, if we look just at CDC numbers, the amount found in the study was twice as much. Then I said, okay, what about, do you think you have a learning disability or related condition that was not diagnosed? And over 13% of the respondents said they did. So the potential, if we believe the respondents, may be 20 to 25%. And here were the conditions listed. Far and away, the most common was ADHD. So 44% of respondents who said yes, I have a diagnosed or non-diagnosed condition, said yes to that. Second most common was dyslexia. We also had a lot of people in the other category. However, when I looked at those comments, almost everyone described dyslexia. I had problems with retaining reading or information I read. If someone read to me, I understood the information so much better than if I had to read it. Any accommodations? So typically, students will get accommodations for learning disabilities or for other reasons, such as extended time on tests, maybe a peer tutor or someone taking notes for them. We had 19 individuals say they got extended time for tests. One person had an assistant or tutor provided by the school, and that was it. No other accommodations. And what has been found, especially with ADHD, the most common condition identified, is if extended time for test is given, and that's the only accommodation, the tester will do worse. So this might not be ideal for our students. It is worth noting that 20 people said they got accommodations out of 103 respondents saying they had a diagnosed or undiagnosed learning disability, which is consistent with other research saying that once students get out of primary and secondary education, if they are able to receive accommodations, they don't request them or just don't get them. Then I said, well, will this have any relation to ability to pass the licensing examination? And what we found is that a number of people needed more than one attempt. One person actually said they did not pass the licensure examination, which was a little confusing because I only sent this to licensed PTs and PTAs. What are you going to do? But then we looked at the numbers, and 16%, a little less, about 15.9, who had a diagnosed learning disability required more than one attempt, and a higher amount, so almost 18%, 17.7, without a diagnosed learning disability required more attempts. So not much of a correlation there between learning disability and inability to pass the MPTE in individuals who became licensed. And I asked for other questions. Some people wrote that they had difficulty understanding the questions. A lot of people wrote about other things that I didn't include in the survey, such as photosensitivity. People reported on other people in their graduating class, such as individuals who were legally blind. And then a lot of people describing symptoms of, dyslexia. And then if we looked at PT versus PTA, diagnosed versus undiagnosed, not much of a difference. Then we look, again, males versus females, a lot more females, but again, we had a lot more females complete the survey. If we look, diagnosed versus undiagnosed, a lot more males had diagnosed and a lot more females had suspicion of undiagnosed, which is very common in the literature. And it's thought that, a lot of children are diagnosed school age, maybe elementary school, where, little boys might be a little bit more rambunctious, and if you're, you might be a little bit more likely to be diagnosed versus young women are less likely to be diagnosed. Right? That's prevalent throughout the special education learning disability literature. Some other limitations to the study. This was only among licensed clinicians. What I'd like to do with future research, is look at individuals who maybe did not pass their MPTE, because what if those individuals have a lot higher amount of not passing the licensure exam, maybe they could benefit from accommodations or specialized instructions or some other things we give to our students with learning disabilities. I surveyed individuals licensed in Arkansas, Ohio, and West Virginia. Why those states? Well, that's where email lists were free. Well, really, other states charge, and some states just don't have email lists available of their clinicians. And there's other limitations just due to being a survey. Not everyone will answer it, and maybe the people who answer this are more likely to have a learning disability or be interested in that subject than people who just, delete the email that's sent to them. All right, so there are my references, and I guess I'll take questions after the break, so thank you very much.
All right, thank you, Dr. Ashby. Our final presentation will be delivered by Dr. Mark Durnach. The title of his presentation is Long-Term Influences of Service Learning Experiences on Graduates of a Physical Therapy Program, a Survey Analysis.
Good afternoon. This is the title of my research, and these are the colleagues that assisted me in this research study. I am a professor of physical therapy here at the university and have a long history of doing service learning, both locally, regionally, and internationally. And I like to look at the outcomes or the influence that this type of teaching has on the students who graduate. Why do we want to know this information, or who cares? Well, one reason is that the healthcare in the United States does not have great outcomes when we are compared internationally to other countries. And so we have to start investigating. We have one of the costliest systems of healthcare, but why are we not producing outcomes comparable to other nations? In 1910, way back in 1910, the Carnegie Foundation asked Abraham Flexner to look at the way physicians are educated in this country, because there was a lot of variability throughout the country. And they wanted to standardize the education to make sure to elevate healthcare to the people of the country. And what the Flexner report started was the establishment of a standard form of education of physicians that emphasized the scientific method and research. So it was very data-driven and very much in that Nagy model of disablement, where we attempt to address a pathology in a patient and fix them. That emphasis on the scientific method has led to dramatic changes in healthcare in the United States, which leads the world in high-tech intervention and research. But it falls short on those other social determinants of health, those public health issues. Frank, 100 years later, did another survey and study of the education of physicians and other healthcare providers, namely nurses, around the world, and looked at the distribution of those practitioners around the world and highlighted the disparities that countries have, where some have a lot of access to service and others do not. And it also talked about the need to make changes, significant changes, in the way we educate men and women to be healthcare providers to others. Big issue was to foster interprofessional education and collaboration, and to promote more community-based education, where the student of health goes into the community and works in their community with the people in a variety of settings that may not be your standard hospital or clinic-based setting. At the same time, the World Health Organization produced the first World Report on Disabilities, which highlighted the major disparities of health for people with disabilities, especially in developed countries. One of the things is, in the developed countries, children who are born with a disability, 2% of them have access to rehabilitation services. 2% of the children in developing countries have access to rehabilitative services. Something has to change in our education to make a difference in the lives of so many people who are not benefiting from our current structure of education. That's why we decided to look at service learning as a way or pedagogy of teaching and its effect on the students in a healthcare program, namely physical therapy. Service learning in the literature varies by its definition. So the first step is coming up with an agreed upon definition for what is service learning. And in our agency, we said service learning is a teaching and learning strategy that integrates an active participation in service. The key point, though, is with instruction and reflection. It is not volunteerism or just going to different places and providing physical therapy services. It is being much more intentional. It is tied to a structured academic program with learning outcomes. The people who participate are evaluated on their experience and their skills, and very importantly, they have to have a reflective piece where every day they would reflect upon how well they provided the care to the people that they served. What did they do? How effective was it? How did the patient respond? What could you have done differently? Which, for the students here, should sound very familiar on clinical reasoning types of development and critical thinking skills. And then if you look at the literature, there is a lot of support in the literature for service learning as a pedagogy of teaching, especially in the area of physical therapy. There's a lot of short-term benefits. It is shown to improve communication, awareness of cultural differences, and fosters collaboration. But all of these studies were taken by survey upon graduation from the professional program. There wasn't information on, is that true? You say you are going to be engaged in your community, but do you do that? You say you're going to follow the APTA's core values, but there was nothing in the literature that looked at that, like what was your behavior after you graduated. So that's what we decided to do. And the American Physical Therapy Association has core values, which are listed on this slide. These are the core values that we instill in the graduates of physical therapy, and we hope that they continue to reflect upon these values and implement them into their clinical practice. So what we did is we did a survey analysis, which was very common in this area. When we looked at a lot of the short-term studies, they're all done by surveys. They're surveying new graduates. We were going to survey practicing clinicians. Well, when you do that, there's a lot of risk in research. Is that survey valid. So we came up with 11 questions that we were going to ask, and we looked at each question and sent them out to a group of 10 professors and educators in physical therapy, and they follow what they call a think analysis, where they look at each question to answer, is this question clear? Does the answer relate to the question? Is it easy to answer? Are there instructions that tell you, how to answer the question? So the think questionnaire was just to look, is the study clear for the person who is going to be participating? Once we got the feedback from those 10 individuals, we made changes to the survey, and then we sent it to 20 people who have participated in physical therapy service learning programs and got their feedback. And then we looked at internal consistency of the questions and answers. We did the Cronbach Alpha, and we found that it was a very consistent and internally reliable survey. So that was good. So then we sent it out to 289 graduates of the physical therapy program to see how they would answer these questions. And we picked it, and also, because everyone's so, we're going to be lifelong learners, engaged, and all of that, we have to give you a $50 Amazon gift card if you filled it out and returned it. So we had to have that as part of our study as well. And the survey itself has the basic demographic information and then some closed-ended questions using a Likert scale, and then 2 open-ended questions. And these are the questions. I highlighted in red those questions in which more than 70% of the respondents said that they agreed or strongly agreed with this statement, that their service learning experience increased their awareness of the APTA's core values, that their service learning experience led them to learn more about different cultures. And in this service learning curriculum, we do local and regional because we also emphasize the socioeconomic cultures in states and how that generational poverty is a culture within itself and how people who live that experience do have different perspectives. So we included that as well as the typical definitions of culture. Their service learning experience made them more comfortable working with people from different cultures, and they became more aware of their own biases and prejudices part of the service learning experience, which I think that reflective piece really helps when people are asked to think about what do you think about those comments that you made to the patient? How did they respond? How could have you done that differently? I think that is very helpful. The service learning experience helped them to become more aware of the needs of their community, which is also interesting because many times people aren't aware of all the services that are available in their community. And service learning with physical therapy students was not limited just to like healthcare. We went to soup kitchens where we give out food. We talked about nutrition and the portion sizes and the nutritional value and the access to food and food safety in people. We went to other shelters for people who don't have another place to live, and we provide assistance to the people in that area. And then they strongly said that they have a responsibility to serve their community. Many of these are supported by other works by Brodsky and Hayward, who found very similar types of responses from their surveys that looked at upon graduation. Ours looked at students who have been practicing for 2 to 7 years that are now practicing clinicians. We took the information, we did a frequency distribution on the closed-ended questions that use the Likert scale. We did the general demographic types of information. And then when we asked the patients how many days per year do you participate in pro bono services and how many days a year do you participate in a community service, we then broke those down and grouped them into a number of days, like none is 0 or less, low is 1 to 3 days per year, moderate was 4 to 7, and high was 8 or more. And then we did an independent t-test to look to see if there was a difference in the response between the men and women who responded, and there was none. So the answers were not different based on the sex of the responder. We had about 30% were men, 70% were women. The average age was about 29 years. They were practicing between 2 and 7 years. So here were some of the interesting questions that came out of this survey. 62% of the physical therapists stated that they were active in the community in the 2 years prior to the service learning experience. Because not only does the research talk a lot about how does the graduate feel upon graduation, but we were thinking, well, what if they already were doing service? You know, does that mean that our experience that we gave them changed them? Like, we don't know. So 62% of them were participating in their community prior to doing these service learning experiences. Currently, 91% of them were. And this was statistically different. And really, we might have thought, well, you're a physical therapist, so of course you're doing more community health types of service. But they weren't. Only 36% of them were doing community health. Others were doing like nonprofit assistance, helping out with different neighborhood programs or reading programs in the library. They did a variety of different types of community services, which was nice to see. Only 44% stated that they were more involved because of their service learning experience. Even though more of them were doing it, only 44% attributed it to the experience they had in service learning. 70.9% stated that the service learning experience made them more aware of the services and the needs of their community. This is also supported by other research by Brodsky. And 93% physical therapists said that they have a responsibility to serve their community. And that's a really high percentage, again, supported by other people's research. Once students graduate, they feel that they have this responsibility not only to their own personal lives, but to communities in which they live. Interestingly, the amount of pro bono services really wasn't that interesting. You might think they would be doing more, but they really weren't. It wasn't that clear. In fact, our survey wasn't able to really tease out that information, and we discussed this for many reasons. One is that during this time period as well, the Affordable Care Act was passed, which provided more insurance opportunities for people who don't have insurance, such as the small business owner and farmers. So maybe the need for pro bono work has diminished. 91% said that this experience led them to know more about different cultures and that they became more comfortable working with people from different cultures, which is great because the population of people that you are going to treat are going to be very different than you. And understanding, having an awareness of that, and being comfortable dealing with that type of situation is important. As well as the 73% stated that having a service learning experience that is structured, as ours were, made them more aware of their own biases and prejudice. And 93% of physical therapists stated that their service learning experience increased their awareness of the APTA's core values. Now, I think that's great. We did not go into, what are you doing that shows that you're altruistic or compassionate? So that would be kind of a different study to follow this up on. But actually, for a practicing physical therapist to say they are aware of the core values was good, because in order to be compliant with something, you have to be aware of it in the first place. So in conclusion, what I can tell you from this study is that participating in a service learning experience in your physical therapy education will increase your participation in the community. It does have that type of an effect. And we know that it has that short-term effect. They say they are going to, and guess what? They do. They also are very much more aware of other cultures, and that they are aware and adhere to the American Physical Therapy's core values. So our community needs you, our country needs you to participate and engage in society and to bring up our health care and healthcare outcomes in the future. So thank you for listening.
Thank you, Dr. Dernach. We would now like to entertain and invite any questions from the audience. We do have a microphone in case you do have a question, and your questions could be for any of the 4 different groups of presenters today. So just take a moment. If you do have a question, please raise your hand or stand up, and Dr. Schrader will bring a microphone to you.
Mine's for the group that did the hip rotation strength and the low back pain. They're going to look
So
at
if some of you would like to come up, you can use this microphone and answer the question.
I actually have 2 questions.
Oh goodness, I didn't sign up for this.
One is relatively simple, and I know you don't have the numbers right in front of you, so ballpark is good. I was just curious as to how many, and I apologize if you had that on your slide. How many did you have with pain and without low back pain? Do you have a ballpark idea?
Were we about 50%? Yeah, so it would have been about 25 of each.
Oh, that's kind of cool. Okay. My other question is, why do you think there was no significant difference in hip strength between the groups?
Yeah, I think there could have been a few different things. First, our small sample size could have played a factor. It would be interesting to see if we did sample people, not only a larger sample size, but of more different cultures and maybe different areas across the country to see if there were any differences. I also think that manual muscle testing, although it's been proven to be more reliable than like machines, might not maybe pick up on like small discrepancies between strength of like people with low back pain and without low back pain. So that could play a role. Yeah. Any other questions for our group?
Are there any additional questions for any of the other presenters or groups?
I have a question for Jason. Jason, where are you? Ashby.
Dr. Ashby.
Yeah. I was just curious with the test, with the licensure exam, did any of those participants that did have a learning disability, were they given an accommodation? Did you check on that? Because I wondered if it would have made a difference whether or not they had the accommodation with regards to the number of testing that they had to do.
That is an excellent question. Short answer is no. I did not ask about that. Actually, though, I did ask. I went to Virginia for a test item writing workshop, and I went to the NPT and I asked them, do you have records of accommodations given to testers? They said, we can't give you that. I said, no, I'm not just, I don't just want it for whatever. I'm doing research on this. They said, no, we can't give you that because we don't keep records. And just anecdotally, which, for whatever that's worth, speaking to many students, at least in the past, receiving accommodations on the NPT is extremely difficult. Now, it's my understanding that they're taking steps to make it a little bit less difficult, excuse me, Freudian slip, but at least in the past, it's my understanding students have great difficulty getting accommodations, even if they had them during school. You have to have proof of receiving accommodations during your professional education. You have to have a recent, so within 3-year letter from a physician stating that you do have a learning disability, which I think is a little ridiculous because you do not outgrow learning disabilities. They stay with you for life. You don't just get better from this. So, yeah. Thank you. Other questions about the survey? Thank you.
Okay, for our remaining presenters, were there any questions regarding the Foursquare step test study or the service learning study performed by Dr. Dernach? Okay, thank you. Let's give one more round of applause to all of our presenters. So this concludes the research forum portion of our event tonight. If you are a clinician here for CEU credit, you may leave at this point if you would like to. If you check out on the way out at the same table that you registered, you will have a learning assessment available to you, as well as a course evaluation, and you could receive your CEU certificate this evening. What we will do moving forward is we will take a break until 6:20. So please use this as an intermission, get something to drink, something to eat, and we'll resume at that time.